So, welcome to the podcast. Today's guest is Jos de Blok, who is the founder of and CEO of Buurtzorg, which is a Dutch organization with more than 10,000 employees, offering community-based home care services to more than 70,000 patients. The Buurtzorg model is spreading throughout the world, really, to countries like Sweden, the US, Belgium, Japan, China, etc., Germany, Scotland, UK. And recently, Denmark has made a first attempt at implementing the Buurtzorg model as well. You went to Denmark recently for a conference hosted by the Prime Minister. So there's a lot of attention to the Buurtzorg model. So thanks a lot, Jos de Blok, for joining us. Just on Jos de Blok as a person, he's a nurse by education, and before he established Buurtzorg, he had several senior management positions in home care organizations. But you left those, and you joined and you started Buurtzorg. So I would call you a care service entrepreneur or a welfare state entrepreneur. Okay, so we have Steve Jobs, who is a sort of IT entrepreneur, and you're a welfare state entrepreneur. Would you like that title?
Oh, I don't. Usually, I don't spend so much time on titles, so I don't. I'm a nurse.
Well, let's call it a description instead.
And but entrepreneur also. I think it was needed to change some things in healthcare, and I had some ideas about how it could be done in an entrepreneurial way. But I don't see myself as a businessman or an entrepreneur. So, I think I developed some skills in my life as community health nurse, which are very useful for what I'm doing now.
Yeah. Okay, I want to jump straight into, there are a lot of podcasts out there where you spend some time explaining about your life, and that's great, and people can Google that or find it on the podcast app. So I want to skip straight into what is Buurtzorg actually? What are the central elements of the innovation you have brought to care services for the elderly, and why has that been successful?
Yes, for me, Buurtzorg is a way of dealing with problems of patients who have severe healthcare problems. So people who are terminally ill, people who have chronic diseases, people who are discharged from hospital. And it's a way of dealing with these problems, which is focusing on outcome and on results. So we said, in many healthcare systems, you see that healthcare professionals are delivering activities, and usually the systems pay for activities. And I said, the process you're going into with a patient is the most important element of what's happening. So you can't predict yet what are the activities you are going to deliver. So let's focus on just the process and try to focus on the result of this process in a way that you can see the quality but also the quantity, the costs of this process.
Right.
So I simplified the whole process. So I said it's not about the different activities. So the nurses should feel free to do what they think is right, and it asks for a certain way of organizing with a lot of autonomy and self decision-making processes. So this the delivery model and the organization model together makes that Buurtzorg is a very different kind of organization than normal.
So you have these small teams of, are they always 12 people? Are they max 12?
No, we have. My idea was that if you are working together in a team, then when you get around 10 people, it's getting more difficult.
Right.
So that you should not become bigger than 10, 12 people in a team. So when teams are growing, then they should split up when they become bigger than 12, or just start a new team. So my idea is that self-organizing teams can organize everything in a neighborhood themselves.
Okay.
As long as they're not too big. But there are teams who say we are with 8 nurses, and that's also okay.
Okay. So self-organizing, how literal is that? That you say they're self-organizing.
Yeah, I think you should take it as literal as possible, because I always say it's a bit like home, that you decide on everything yourself. You see what's going to happen, so you also can have some expectations in what's needed to do. If you do that individually and as a team, then you can see how to manage everything yourself as a person and as a team for the coming weeks, the coming months. So the scheduling, the hiring of colleagues, taking care for your own education, taking care for your own network with doctors, with physiotherapists and other professionals, creating a network in the neighborhood, taking care for your own office and furniture and whatever. So in every way, the nurses and the teams are organizing everything themselves.
Okay. So how is that possible in Holland? Because in Denmark, you have a municipality that decides what each patient in his or her home, or if it's a couple in their home, what they are entitled to.
Yeah.
So there's time allotted to them, and the different teams can't just go out and change that. And you're even a private organization. So how is that possible that you can go out and decide for yourselves, no, we're not going to do this, we're going to do that? How does that work?
No, but the starting point when we started in 2007 was similar in Holland. So there was an institute, and people had to ask this institute for an assessment. And when they got the assessment, then they got also the rights for so many hours and these kind of activities and these kind of products. So that was, at that moment, there was a lot of dissatisfaction about it.
Yeah.
So a lot of people were frustrated about the bureaucracy in the system. The nurses were very frustrated about that they couldn't do what was needed because there wasn't a separate institute. So and if you look at the process, it's similar in most countries. But what I try to show is that when the decision is made by the nurse, it's usually a better decision than when it's done by an institute, because it's not just the one moment you need. You need to know what's going on with this patient, if it's a woman, man, couple. You need to understand the environment of the person who needs something. And then throughout the first weeks, then you find out, okay, what can they do themselves? How can I support them in a way that their self-management is as good as possible? And then what do we need to support that? And this is a process you need to go through. So you can say at the first moment, okay, my estimation is this or that. But if people are able to do things again themselves, that's what you learn in time.
Yeah.
So and with this knowledge, because I am a community nurse myself, with this knowledge, I said, okay, we are going to show that we are not having conflicts with what is decided by the institute, and we even offer the institute to do the assessment, and that they can say we agree or we don't agree. So more or less, so we took over, and in a few years' time, we even
how you if somebody tried to do that in Denmark, to take over, you wouldn't get any public. I assume you get, how does the system work in the Netherlands? Is it taxpayer financed, or is it insurance? Is it out of pocket?
At the moment we started, it was state finance.
Okay.
A bit similar like in Denmark. In 2015, it became part of the health insurance.
A private health insurance or a public?
It's a private health insurance, but it works almost like public because everybody needs health insurance. So.
Okay, so you have an agreement with the health insurance that
Yeah.
you run things yourselves. And why do they agree to that? Aren't they afraid that you're going to end up spending more money? After all, you want to employ more nurses. And if you could just decide to...
No, but from the start, my assumption was that by working this way, the costs would reduce because you are working in a more effective way, focusing on self-support. So there's a very clear vision behind it. So we said, okay, these nurses, their skills, they should use them in the most optimal way. And if they do that, then some of the patients need a shorter period of care. So I was convinced that this would happen. And a lot of patients need less care because we try to learn the environment, how to deal with it.
Right.
We try to learn the patient how to deal with it. So we avoid unnecessary cost. My biggest frustration was about the waste in the system, because I saw that a lot of things were done with patients, which, in my opinion, from a professional and ethical perspective, was not needed.
Could you give an example of that?
Oh yeah, it's very easy to make people depending on you. So if you are coming in every few times a week and you take care for a patient and you don't focus on mobilizing people, training people, for example, when somebody has diabetes, then it's important that they learn to deal with this diabetes, that they can not only take the insulin themselves, but that they are also aware that mobilization, but also weight and other things are very important to have less complications with diabetes. So all these different aspects. So what we saw that this institute was dividing the time on different products, and that's a bit similar as what I see in Denmark.
Yes,
and then they say you have so much time to spend on it, and then you get a focus on the time. But I said, no, the focus should be on solving the problem.
Right.
So I said to all the teams, do work from this vision. Let's create, when it's possible, let's create independency for the patient, being adaptive in what's needed, and try to all the time evaluate if what you're doing is still needed. So this
that's an amazing win-win, isn't it? Because who wouldn't prefer to be independent?
So the assumption with the politicians in Holland at that moment was that people want as much care as possible. And I said, that's not true, because it makes your life so complicated when you are waiting all the time for somebody who is coming at your house. And when it's fragmented, when different people were coming for different tasks, then, sometimes you have 30, 40 different people coming in your house in one time and in 1 month time. So this is a big burden for people.
Yeah.
So to understand the advantage of being independent and not needing unnecessary help, but then if you build a relationship, then it's very important that these professionals, healthcare professionals, have a certain vision in making people as much as possible independent. So, and systems, like I see in many countries in Europe, systems tend to, based on control mechanisms, they want to tell people what they are allowed to do. And I said, it's crazy, in my opinion, if you just trust the nurses that they want to do good things and monitor the results, because it's not just spending all the money without knowing what they're doing. No, my idea was we should know more about what they're doing and what the results are about what they're doing. And then we can measure it. We can, it's very easy to measure the costs per client per year. So I said, if we do this right, then we will see that the costs per client per year will decrease. So that's what we did in 2009 was the first research. So at that moment we had I think 400 teams like that. So 4,000 people. And then Ernst & Young did a big research, and they described what we were doing, and they showed also to the government that by working this way, we saved 40% of the hours. 40%. So it's not just a little bit.
40%.
40%. So this document is you can find it on internet. It's in English, so also the Danish people can read it. But that was in 2009, 2010. There was a second research done by KPMG, 2014. So we were then 4 years. I think we were 8,000 people at that moment. At that moment, they showed the government, the Ministry of Health themselves ordered KPMG to do this research. So it was done based, and it was a comparative study on the average hours spent per patient per year. And the average in Holland at that moment was 168. And in Buurtzorg at that moment, we spent around 108. 60 hours less, which means 35%, because most organizations in time were more and more adopting the principles of Buurtzorg. So you saw in time that the differences became smaller, but still in 2014 it was still 35%. And
sorry to interrupt, but in a Danish context, that would be interpreted as you being 40 or 35% worse. Because I know you're not, but that would be how they would interpret. They would say, well, you're delivering 35% less hours. That means that you're 35% worse. Your service level is 35% lower. Yeah. That would be the logic of the political system.
I can imagine, but what we did was not only measure the hours, we also measured the satisfaction of the patient.
So that's how you dealt with that.
Course. But what I wanted to show was that you had results on 3 different topics. One on the costs, second on the satisfaction of the patient. So my idea was, if you create more continuity, because the small teams create a lot of continuity in the relationship between the patient and the nurse. So
it's a bit like the old-fashioned doctor-patient relationship. That's also
my assumption is if you want to build a trustful relationship, there should be continuity in the relationship. So if there are too many people involved, it's very difficult to catch. And it's also about knowledge. If there are not too many people, you have more knowledge about the situation, and you can do the right things. So what we've shown, and that was also around 2009, I think, that was a research on satisfaction. And from that moment, we could show that the satisfaction was significantly higher than the average in Holland. We had we still have 9.2, 9.3 on a scale of 10, and the average in Holland is around 8. So what you see is that costs went down, satisfaction went up, and then the third one was the satisfaction of the nurses. So we had a big problem with nurses who were frustrated about the system. A lot of nurses quit their jobs because of all the rules and all the regulations they had to deal with, all the bureaucracy, so many times spending on time writing and all these other silly things. So what we said, no, we are going to reduce the time you have to write down. We will build an IT system which takes care for the bureaucracy. And we will ask you to do what you think you should do. So you should be satisfied about the things you're doing every day with your patients, based on a professional, ethical principle.
Yes.
What we saw was that from also in 2010, we did the first research on satisfaction of the nurses, and from that moment we became the best employer of Holland. So we had the highest rates.
Not just in the care sector, but in general.
No, in general.
Wow.
So also the for example, I remember one of the first things, it was between the KLM and Buurtzorg.
Okay.
And I said, we fly higher than the KLM.
What about, I guess some people would, especially in the healthcare sector, would argue that patient satisfaction is not an objective measure. Do you have objectives? What about hospitalizations, for instance?
No, of course. But it was the point you made that it was not only the costs, and if the people said that in Denmark they would say it's worse because you deliver less hours. I think satisfaction is important. So I think
so do I.
It's important how people perceive what they get and that they are satisfied about how you are dealing with their problems. So I'm very in favor of this shared decision making. So people should be in control. So the patient should feel that they have control on what's happening with them, done by healthcare professionals. So
I agree with you completely. I'm just saying, are there
but
objective measures about the quality of the care as well?
That's the other thing, because I said at the moment we started, we only had knowledge about products and time spent on patients. That was the only thing. I said, it should be more knowledge driven. So we need more information about what is the result of what we are doing. So we said we need to measure the interventions and the results of the interventions. So we started to using the Omaha system, which is a client classification system that you say, okay, these are the problems. This is what we do with the problems, and these are the results of what we have been doing. And this is all digitalized. So this is the way we work with the care plans. So it's all in our IT system. So the nurses write down, okay, I've been working with these patients, and these are the main problems. This is what we are going to do about, and these are the results. So we can measure it in quality. So we can, for example, with the diabetes patient I just mentioned, I said if you know more about diabetes, it probably will have an impact on your behavior. So what we measure is knowledge and behavior. So we said the first time we come at a situation, we said, okay, this is 3 out of 5, but it can be 5 out of 5. So, and then when it's 5 out of 5, then patients can deal in a better way with their own circumstances. So this is what we measure. And then we can also connect it with the quantity. So then we can say, by doing this, we see a reduction of the hours. So we can see that the independence and the self-management increases, the cost decreases, so the knowledge and behavior are having a positive development.
Okay. So you're measuring quite a lot.
We're measuring more than what was done in the old system. So we said, but the focus, and that's very important, the focus is that we measure things which are also important for the nurses to know. So we ask the nurses, so it's not seen as bureaucracy, but it's seen as knowledge creation. So they create knowledge about what they're doing, so they can reflect on, okay, are we using the highest standards as a team? Do we have enough knowledge about dementia? Do we have enough knowledge about all these chronic diseases we meet in our daily work? And if we don't, how can we improve it? So there is a continuous learning process in these teams based on reflections on their daily work, supported by the things we measure.
So the way I see it, what you've done is you've given these teams freedom, and that's within a framework of accountability. Yeah,
it's always autonomy, and I would say we don't take away the freedom. So it's not giving the freedom, but not taking it away. Create an environment.
Good point.
Where you say, okay, this autonomy is very important. So the freedom to decide is very important, and autonomy comes with accountability. So you have to, and people want to be accountable for what they're doing, but they also want to have the space to decide on what they're doing. So these two things go together.
Yeah.
So, and everybody's accountable.
In what way? To whom?
To each other and to the patient.
So
So
patients have access to all this information as well?
if they want, it's not, and it's an interesting thing, because what we started, I think 4 or 5 years ago, is to give also patients access to the same system as where the nurses are working in. So we said, if you can create communities, but it's more from a perspective of sharing ideas, expectations, also for families. So imagine that the family lives far away. Son lives in Australia and wants to be involved with the care plan of their father or mother. Then it's, when you make it digital, it's possible. So we work a lot with families, so that families can also be involved in discussing what is needed, who can contribute, how can we be aligned as much as possible, and how can we make this a process which is a collective thing. So then it's not delivering an activity. No, it's about what's happening in this context. What was the history of this person, and how can we connect with the things which are very important for this person? What is the coping strategy? It's not the diagnosis usually which makes the difference. It's about how you deal with the diagnosis. Yeah. So one person with rheumatism acts very different than another person with rheumatism. So you have to understand what is rheumatism still, but you also have to understand that there are different coping strategies, and that as a nurse, you find your own way in how to deal with it in this context, with this person, with this family.
Mm-hmm. So all this data creates information about how individual nurses are performing and how teams are performing.
Yeah.
And presumably there are some differences there. Some perform better than others. How's that information used?
From the start, we said we are going to ask the nurses what kind of information is useful for them to reflect on. And they said, okay, it's good that we have an idea about the differences in different patient groups. It depends. In some regions, they have more patients who are discharged from hospital. Some teams have more patients with chronic diseases. Some teams have more patients who are terminally ill. So you have to understand what are the different patients group we're dealing with. Then we created kind of a dashboard that we can see how they are doing, what are the results of these activities they're doing compared with other teams. So we have the average of Buurtzorg, and they can see, how are we doing, and can we understand what we're doing, and if we're not satisfied, how can we improve what we're doing. So it's all the time trying to not putting pressure on what they should do. They should reflect themselves and ask themselves, okay, are we doing the right things? Are we happy about our results? So we have a few guidelines. So we say the teams are working within 3 main guidelines. One is we want to have the highest quality. So quality is very important. And then we say the quality is about different things. It's about one, satisfaction, but also the effectiveness of our interventions. So we have the professional view on quality, and we have the experience of the patient. So we connect these two. Then we want the teams to be happy about the way they collaborate with each other. So we have some ideas about collaboration, and we want to also that the nurses are also accountable for the financial part. So we said every team has to understand that the percentage of their work needs to be billable. That's the third one. So these 3 guidelines, within these guidelines, they organize their daily work, they make their routes, their scheduling, They decide on how much time they spend on their meetings, and so on. But that's all the decisions made by the teams themselves.
So if you will always have, by the nature of things, 10% of teams that are top performers and 10% of teams that are bottom performers. Do you centrally do anything when you have a team that's in the lower 10%, for instance?
Yes, when we started, we were asking ourselves, what do we need to support the teams when things are not going well? Yep. And based on that idea, we developed the role of a coach. So we said, okay, there will be times that it can be difficult for a team. When several team members are ill for a while, then the pressure in the team goes up, and sometimes they can't solve it themselves. So then they can ask for support by a coach. The coach is trying to find ways together with the team that how they can solve their problems. And then you see that after a while they go up again. So, and I agree with this 10%. It's usually this 10% of the teams which are struggling a bit and need some extra attention, support, and that's given by the coaches.
Okay, so coaches, are they employees in the central administration, or do you hire them in?
No, we have on 45 teams, we have one coach who's living in that region and who is supportive to the teams in that region. So
okay.
So they're regional coaches, and they are connected with each other. So they reflect on the things they meet in teams and are supporting each other on difficult cases, because it's usually the difficult situations when it comes to the coach. So it's also a continuous developing pattern. So we learn. So the coach now has learned from what we did in the past.
Yeah, so I can see that. Yeah, good point.
Yeah.
So I assume sometimes there'll be a team where there's an employee that they're not happy with. They try coaching. They for some reason it doesn't work out. I'll be very surprised if that didn't happen. I've hired a lot of people, and even though I consider myself reasonably good at hiring, I sometimes hire people that I have to let go again, and it's always painful. It's never pleasant. How's that dealt with? Is that the team itself that does that, or you do that centrally?
No, the teams are hiring their own colleagues, and they're evaluating each other. So when they find out that after a while it's not working because of the personality or lack of skills or whatever, then usually they discuss it with this team member. And then when they think, oh, this is not going to work, sometimes they ask for support for the coach, and then the coach starts this process together with this person to find out perhaps she could work in another team, which is because sometimes it's personalities together. It's not always about the skills. And then they try another team. And usually then we start discussion about, okay, when it's not working, how can we deal with it in a way that the nurses are still satisfied about the way they are leaving Buurtzorg?
Yeah.
So we want them that we say, okay, nobody wants to stay if you are struggling with all kind of difficulties in a team, because it's frustration. The frustration is also with the person who is not seen as a good colleague. So then we find ways. Sometimes we ask, perhaps you should do an education for a few years, and then you can come back if you. And sometimes we try to find another job at another place with a doctor or a GP.
Sure. I think the central thing here that's really interesting and different from what you see certainly in Denmark is that it's the team itself that makes the decision. And in theory, and they as I hear you also often in practice, they do it themselves without really involving the central organization.
Yeah,
that's interesting. How big is the central administrative unit at Buurtzorg in Holland?
Yes, when you started, you said we have 10,000 nurses, but we have also 5,000 care workers. So we have we have different parts of the organization.
Yeah,
we are delivering the community healthcare, and there are 10,000 nurses. We have the domestic care parts with 5,000 care workers, and we have several small parts. But in total, we have around 50 people at the back office. So these 50 people are taking care for the salaries, for the billing, for the administration, for the contracts, and for the compliance. So this is what we have for support. So we have these coaches. So we have around for Buurtzorg, we have 22 coaches. For Buurdiensten, which is this domestic care part, we have also around 25 coaches. So these are the people in, you can say, the central organization. So it's around, I think in total around 100 who are doing supportive activities on 15,000 people.
So that's less than 1%.
That's less than 1%.
Yeah. In Denmark, it's about 16 to 20%.
Yes, I can imagine. In Holland, it's similar. That if you have a management structure, and if you have the traditional HR departments, financial departments, IT departments, and so on, then it easily comes to 20 to even 25%. So our idea was, if you look at the problems for the future, if you look at the demography, if you look at the available capacity, then we need to do things in a different way. Yeah. So, and also I had this conferences in Denmark a few weeks ago, and then people said to me, I think we have 20 to 25% people working in overhead roles. And then I said, perhaps one of the topics also in Holland is that how can we use this capacity for taking care for people? So we have at the moment, I think we have 600-700 people who have done other jobs before and are now following an education as a nurse. Some of them are 50 plus, but they are very motivated to become a nurse. And they said all these experiences we had in the past can contribute to what we are going to do. And the teams are very happy with this senior people who are now doing another education. So from a system perspective, it would be good to say, okay, what kind of solutions can we think of if we say how to deal with demography and capacity? How can we deal with the financial part? So if I understand well, then Denmark has a system where the personal care and the nursing care are split. So
yes, it can be split. So the private providers don't normally provide any nursing.
Yeah, so we said we combined it. We tried to, if you want to deliver this community care from a holistic perspective, then and you can combine it. Then it has also a positive effect on the capacity. So, but then you have to look at it from a system perspective.
Yeah.
So and because when you're in the community and you have the responsibility for this part, then you will defend this part. So, and my idea was, if you look at it from the patient perspective, and what do we want to achieve as a healthcare system in Denmark, then you have other options, other ideas, but I think it's very interesting because I have these discussions in a lot of countries. Is how can you change the payment system in a way that is supporting the results for the patients.
Yes, that is essential. I'm an economist, so that's all. Incentives, it's not the only thing.
Yeah,
it's certainly not the only thing. Your system would not work if the nurses didn't have this pride in what they're doing. Yeah. That's essential. But you can destroy that with bad incentives.
But I also look at it from an economical perspective. So I should also have become an economist. I was.
I know. I listened to some podcasts. You have a very interesting story. The only reason why I don't delve into that is that I want this the limited time we have together. I want to talk about how the system actually works and pick your brain on that.
But then you should not underestimate the economical idea behind it. So my concern was, if we go on like this, that it for the coming 10, 15 years, the accessibility and the availability of community healthcare would decrease, and would also the quality would decrease. So my idea was the costs are going up too fast. So we have to find ways to decrease the cost and the pressure on the capacity. Yeah. And for me, that's an economical issue.
Yeah. But it's also an entrepreneurial activity. Going back to what I said in the beginning, that's what entrepreneurs often do: reduce cost, finding innovative ways to reduce cost while increasing quality. So I have a few questions, and we don't have that much time left. Do stop me if I go too far, and we'll just cut that out. So what I'm curious about, how could Buurtzorg grow that fast? So in Denmark, if you're a private provider of healthcare, you will be located in one municipality, and the other municipality would not necessarily use you, and it is very difficult to spread quickly. How is that possible? I mean, you went from one team to basically 1,000 teams, I assume, if they're an average of 10, and that's just of nurses. Then you have the other care workers on top of that. How's that possible within 15 years?
Yeah,
10 years.
10 years. It was in the beginning. It was seen as a kind of an experiment. So in 2007, we had around 12 teams over the country, and it was possible because of the Dutch system. So I could get agreements in different regions. So it was not with municipalities, but with regional care offices within the state funding.
So you didn't need agreements with regions. It wasn't just that patients could pick you just like that all over the country.
In Holland, we have 32 regions, and I needed agreements with all these regions.
Okay. So why were they so willing to make agreements with you? Weren't they providers themselves? Didn't they see you as competition?
There were providers, but at that moment in 2007, there was a lot of frustration and dissatisfaction, and I wanted to give access to new innovative providers. So there was a search for, we want freedom of choice, but you also want to reduce costs. So the idea, but reducing costs was focusing more on reducing prices per hour. And I said, no, you should focus on costs per client per year.
Yeah, exactly.
If you reduce the price per hour, probably the people won't do the things anymore which are needed to make it more cost effective on a perspective of a longer time. So what I said is, if you do the right things with the right education level, then perhaps it's more expensive per hour, but the costs per client will go down. And that's what we've shown all throughout the years.
Yeah.
So then even the law, they changed. The Minister of Health changed the law, in that this assessment institute, what I talked about in the beginning, was moving, and the nurses by law were allowed to decide on the amount of time they need to spend on patients.
How is the initial reaction by nurses unions or the nurses union in Holland?
No, in Holland, it was very interesting because I said I want to increase the satisfaction of the nurses, and I want to focus on their development. But I had a discussion with the union that I said, but what about the secondary things in work like salary and other things? I said we also should increase them. So we didn't have, because we paid more in the beginning. We paid more than the average home care organization in Holland. So we said, I was not happy with the way that the union was getting the agreements. I said we need to do more, and at the moment we are in the same position in Holland. I said we are going to next year we're going to scale all the different roles we have and put them in a higher scale. So it will take some money, of course, but we will find the ways to deal with it. So the burden, the pressure is coming up because of the demography.
And you're increasing the productivity of the nurses by allowing them to use their skills in a much more in a much better way. I see. If you increase the productivity of a worker, you can also increase their wage without increasing costs.
Yeah, no, but that's one of the things we're doing. So we, as I already said, we decrease the hours every year. So that's on a system level. That gives a lot of opportunities for the country, for the whole country. The other thing we're doing is by changing the patterns and for example, we pay a lot of attention on prevention. So we said we have to move from the delivering activities to prevention. How can we prevent that people need? Now, teams are training, doing all kind of experiments, and my idea is that if we focus more on prevention, it's not. You can do it in the afternoon, for example. It's not as taking care for patients usually is done in the morning. Then you can do this in the afternoon, and when you have this good combination of things, the productivity will increase. That's my assumption for the coming years.
Yeah. I read somewhere that you, for instance, if you make new decisions about how overtime pay should be structured, you write a blog, and all your nurses or care workers can comment on that, and then you often make a decision within 24 hours on how to change that. So if everybody agrees, it's easy. If somebody disagrees, you can have discussion and you can change it a little bit, and that's it. And that's interesting as a management tool in itself. But what it made me think about was how does the salary system actually work? In Denmark, you couldn't do that. You have the union that negotiates with the municipalities, and that creates the wage structure, and you can't change that.
No, but that's the starting point. So we also have disagreements in Holland, and we say that's what we agree on. But then you can do extra things. So
okay.
and then we it's not only the blogs, but also I have every few months I invite people to talk about topics on a more or less an organizational level. So I want to invite them to say, okay, what are the topics you can't deal with in your team, and should be kind of a guideline on a national level. For example, the availability in the night was one of the topics. So we said the teams are 24 hours available. That doesn't mean that they are working, they're sleeping usually, but it is possible that they got a question in the night or a request. Yeah. So then we sit together, we said, and then I ask a group of nurses who are representing teams to give an advice. So, and then they say, okay, we think that this payment for having this in the night is reasonable. So and then then I will take over, and that's the topic. So this is the way because it's important that people feel that that's a serious topic which can be addressed by anybody, and that there is an answer coming out which is connected with how they feel it in their daily work.
Right. Okay. Sounds like a great organization. But I think there'd be, I know we have to finish, but just one last question. It's okay.
Yeah.
There would be, I can imagine what kinds of barriers there would be to implementing a truly Buurtzorg system in Denmark. So we'll have resistance from the bureaucracy, the 16-20% or the 25%, as you even claim it might be, who would become redundant in this system.
Mm-hmm.
There would be cultural resistance from having a private provider come in this manner, and a cultural resistance to benchmarking. The information you mentioned that you have available in Denmark, it's hard even to find out what the total costs are in a municipality of care for the elderly.
Yeah,
we sometimes try to find that out, and it's actually quite difficult given the way accounts are made. Yeah. So there's cultural resistance to benchmarking, and it's certainly to making that information available to the general public. Yeah. How have you dealt with all that, and how would you recommend that we deal with that in Denmark to be able to create this change?
No, I understand. I think I've been enough to Denmark to understand this, the differences. And I think the only way I can think of is that we find a way to deal with this in a dialogue. So we need just to have an open discussion. And for me, the mentality in Denmark is very open.
Yeah.
So there isn't. It's not a taboo. It's perhaps I understand the public and private part, but what I said in Holland is that we started a private organization. They're all private to act public.
Yeah.
So I see that we are serving the public cause. So we are not for profit, and we created a kind of a public space in a private environment. And I would like to discuss this with municipalities, because for me, it's not about public or private. It's about how can we build sustainable ways of dealing with the problems of vulnerable people, and how can we do it in a way that we use the capacity as effective as possible. Yeah. And so there are general topics, and I understand the sensitivity on these topics, and I think they have a big value because I agree with them. So, and then it's not that we are have different ideas about it. It's only the history and the culture and the way it's organized at this moment, which creates this kind of tension in when you talk about this topic. But always with every topic I had in Holland, I started the dialogue. It's about the content. What do you want to achieve? How does it work? And how can you come together with this topic? So I'm really very optimistic about Denmark and everything what's going on, and let's try to find ways to solve these topics and issues.
I hope you're right. You've really created an amazing organization, and a way in which it has challenged my prejudices and ideas is I would have thought initially that a non-profit organization would not have the incentive to expand that quickly and to scale up. And it's that has made me rethink. I'm a free market guy, and I like profit, but that's really made me rethink some of my ideas about what's possible in a non-profit model. And that's very, very inspiring. And I salute you for the work you've done. And I really hope that we can spread this around the world. Thank you, Jos de Blok, for joining my podcast. Is there any final thoughts you want to deliver? No,
I think it's for me. It's not about profit or not profit. I think it's creating a society where you can use the different elements of entrepreneurial things but also taking care for the public part. For me, there needs to be a balance in both. So
I agree. Profit is not the aim. It's a means. But in this case, the means wasn't needed, and that's very, very interesting. Thank you, Jos de Blok, for being part of my podcast.